Okay, Nancy, I'll start now, Nancy. Yeah. So, good morning, everyone.
Yes, you can begin. You can share your screen and begin.
Okay. Okay, good morning, everyone. Just like our usual program, we are now starting the 25th, 25th epo of this teaching session on grand rounds. So, as usual, we'll start with, I think I'm audible to you all now. Nancy, I'm audible now?
Yes, sir. Yes.
Yes, sir. Yes, sir.
Yeah. And start with the short case first. What does this video show? I'll show the Ask the patient look up, now down, look up again, down, down, turn to the right, look to the right, look to the left, the right, to the left, into the right, up, down. Okay. What do you think? What are the abnormalities I noticed in this patient? Anyone can unmute and answer, please. Anyone?
When she's, sir.
Tell me, please,
Hello?
please. Yeah, I can hear you, please.
Yes, sir. When she is looking to one side, the eye that is adducting is showing a decrease in the size of the palpebral fissure. And when she is looking up, the left palpebral fissure is less. There is like a ptosis, and when she is looking down, there is a lid lag in that eye.
Perfect, perfect. So what your observation is perfectly right. So what is this patient having? Your observations are perfect. Now let's take the first the ptosis part of it. Okay, this ptosis, once you see this phenomena, that is lid lag on looking down, along with ptosis, there is only one condition, that is a congenital ptosis. So if you find such a phenomenon, you need not investigate further. It's a congenital ptosis. Okay. The other one, when the patients look, when the eyes goes in the adducting eye, the palpebral narrows is actually because of the retraction of the globe. So what is this condition? When the eye adducts, the eye retracts, the eyeball retracts.
Duane's retractions.
Yeah, that is Duane's retraction syndrome. This is because of the simultaneous contraction of the lateral rectus and medial rectus. So that in addition to the adduction, which is more contracted than the abduction, the eye also retracts backward. Now you can see this ptosis once again. This is very, very important. Looking down, the ptosis. Looking down, the ptosis is obvious. But if see the eyelid retracts, there is a lag on the left side. That lag indicates that there is a fracture or fibrosis, contraction, fibrosis of the LPS muscle, telling you that there is abnormality in the muscle. Congenital ptosis. And subsequently, the other finding, you can find that the adducting eye, the palpebral narrow. Okay. So with that, go to the.
Sir.
So this just got any questions on that?
Sir, excuse me, sir.
Yeah, please.
Sir, that part wasn't audible, sir. Sir, when the patient is looking down and there is lid lag, and looking up there is ptosis, it is suggestive of
congenital ptosis. Congenital ptosis.
Okay, sir.
Yeah.
Oh.
It's not an acquired cause like a third nerve palsy, like producing LPS paralysis or levitic. That's an important point to differentiate. Okay. Okay. Then I will put the.
Okay, sir. Okay, sir.
Yeah. I'll go to the next case now. Say 56-year-old hypertensive lady has presented with acute onset of dysarthria, dysphagia, and right side hemiplegia of 3 days duration. Look at the video of the patient. I will show the important finding. What is his name? This is Mary Mohan and said,
വീട് എവിടാ?
is her house?
തിരുവനന്തപുരം എന്ന് പറഞ്ഞേമ്മ.
It's a
ക്ഷമ ഞാൻ പറഞ്ഞ പോലെ ചെയ്യണേ അമ്മ.
Then ask the
നേരെ ഇവിടെ നോക്കമ്മ, ഇവിടെ നോക്ക്, ഇവിടെ നോക്കമ്മ, വരലി നോക്കേ, ഇടത്തോട്ട്,
ask the bed to the left side,
മുകളില്,
up,
താഴെ. ശരി, കണ്ണ് മുറുക്കി അടച്ചമ്മ.
close the eyes bilaterally. This bilateral orbital lens weakened.
പല്ലി
The face deviation is to the left side, more on to the left side.
പല്ലി കാണിച്ച് ഈന്ന് കാണിച്ചേമ്മ, ഈന്ന് കാണിക്കേ. ശരി, അടച്ചേമ്മ.
The opening is okay.
ഇനി വാ തുറക്ക്.
They asked to say hardly any palate.
എന്ന് പറഞ്ഞേ, ആ പറഞ്ഞേ, വാ ശരിക്കും തുറക്കാം. ആ പറഞ്ഞേ, ആ പറഞ്ഞേ, നാക്കൊന്ന് നീട്ടിക്കേ, നാക്ക് നീട്ടെ, നാക്ക് ഇടത്തോട്ടും വലത്തോട്ടും തള്ളിക്കേ, നാക്ക് നീട്ടിക്കേ, വാ തുറന്നേ, വാ തുറക്കേ, വാ തുറന്നു. ഇനി ഇടത്തോട്ടും വലത്തോട്ടും തള്ളിക്കേ, വലത്തോട്ട്, ഇടത്തോട്ട്, നല്ല തള്ളി. ഇനി വലത്തോട്ട് തള്ളു, വലത്തോട്ട് തള്ളു, വലത്തോട്ട് തള്ളിക്കേ, ഈ വശത്തോട്ട്, ആ തള്ളിക്കേ, വലത്തോട്ട് വരട്ടെ, ഇടത്തോട്ട്, ഇടത്തോട്ട് നോക്കി തള്ളിക്കേ, ഇനി വലത്തോട്ട്, 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 വലത്തോട്ട്. മൈ കൈ പൊക്കിക്കേമാ നോട്ടെ. മൈ കൈ കൊണ്ടിട്ട് വിരലേ തൊടണേ, വിരലേ തൊട്ട് മൂക്കി തൊടമ്മ, വിരലേ തൊട്ടെ. ഈ കാല് മടക്കിക്കേ, ഇത് മടക്കേ, ഇത് മടക്കമ്മ, ഇത് മടക്കിക്കേ.
Right plantar is upgoing and left plantar is up.
ലൂസാക്കിയിടമ്മ. കാല് വലിക്കല്ലേ, കാല് വലിക്കല്ലേ. ആ പതുക്കെ തുറക്കമ്മ. അത്രയും വേണ്ട, പകുതി പകുതി പകുതി.
Okay, I'll show the one more important finding. I'll show the video once again.
ഇത് പറഞ്ഞേമ്മ.
The ocular bilateral
പല്ലി കാണിച്ചേ,
you can see orbicularis is deviate to the left side.
പല്ലി കാണിച്ചേ, ഈന്ന് കാണിച്ചേമ്മ, ഈന്ന് കാണിക്കേ. ശരി, അടച്ചേമ്മ, തുറന്നേമ്മ.
No parietal movement. Look at the tongue. Tongue is deviated to the right side.
നാക്ക് ഇടത്തോട്ടും വലത്തോട്ടും തള്ളിക്കേ.
And
നാക്ക്
it deviated to the right side, but able to move tongue towards right side.
വാ തുറക്ക്, വാ തുറന്നു. ഇനി ഇടത്തോട്ടും വലത്തോട്ടും തള്ളിക്കേ, വലത്തോട്ട്, ഇടത്തോട്ട്, നല്ല തള്ളി. ഇനി വലത്തോട്ട് തള്ളു, വലത്തോട്ട് തള്ളു, വലത്തോട്ട് തള്ളിക്കേ, ഈ വശത്തോട്ട്, ആ തള്ളിക്കേ, വലത്തോട്ട് വരട്ടെ, ഇടത്തോട്ട്, ഇടത്തോട്ട് നോക്കി തള്ളിക്കേ, ഇനി വലത്തോട്ട്.
The findings, so on examination she had effortful, strained speech, ocular movements were normal, bilateral facial weakness, right more than the left, no parietal movement. On asking the patient to say ah, tongue movements are bilaterally restricted but more prominently towards right side. She does not push the tongue towards right side. Right hemiplegia, pandas upgoing bilaterally, no cerebellar signs on the left side. So these are the findings in this patient. So where do you think is the Georgia is absent? GAG should not cooperate for GAG testing, so I did not couldn't do the GAG. So where is the localization?
Sir, it is above pons. Above pons on the left side. Since she has weakness of the right facial, left facial also. I think with the single lesion in the pons we can explain that, but it should be above pons on both. On the left side.
That means it has got a facial pulse is bilateral, so lesion has to be in the upper pons bilaterally. That's what you're trying to say. More on the left side, correct?
Yes, sir. Yes, sir.
But the problem is the Georgia is absent. Is the tongue lesion a lemon or a lemon?
It's a upper motor neuron lesion, but I mean, because in it's a special plantar and it's a hemi-disc distribution on the, I mean, on the right side. So everything looks like a upper motor neuron only, but it's difficult to I mean, explain the left-sided facial weakness as well as the palatal weakness. Probably some mild lesion on the opposite side as well.
So why can't be a bihemispherical lesion? Patient might have had an old infarct on the right side producing left cortex bulbar involvement which remains silent. Now developed a left hemispherical lesion producing the same thing.
In that case, the reflex should have been brisk, but the reflex, I mean, the facial what would the facial reflexes in this case?
Facial reflexes are not elicited, but I did that pout reflex that was absent, Georgette was absent. But if you think of a lesion in the upper brainstem also, this is the same thing should have been. We expect joy also to be brisk.
Can it be medulla, sir? Medial medulla?
Yeah, that's another possibilities in the medulla. Only thing is you've got a facial involvement that can involve, but only if the medullary lesion producing facial palsy, it only produces perhaps the lower part of the face. It will not produce upper part of the face. Here both orbicularis also are weak.
Okay, sir.
Fibers which loop down to the medulla are the fibers destined to the lower part of the face. Because as you said, gag is Georgic absent with the bilateral participant medulla is a very good possibility. But this point is against bilateral facial involvement. And the speech appears more like a spastic speech to me. Okay, so let's go to the, is it bihemispherical possible? Brainstem. If so, where in the brainstem? Okay, you want to, let's say the MRI of the brain. There is no lesion in the hemisphere. Okay, so the possibility of a bihemispherical infarct, which this is in fact, this presentation is more common with a person who had infarct earlier, not coming with another infarct on the other side, left side. They come to with unmasking of the spastic speech, unmasking of the cerebral palsy will occur. But the odd point is absent Georgette. We should have been brisk in that case. So can the lesion be in the medulla where we can explain the absent Georgette also? There is no lesion in the medulla. Now my question now is the lesion in the midbrain or in the upper pons, as Dr. Umar was telling, because of the spastic speech. Hemispheric lesions ruled out. That is, if the bulbar palsy, LMN or EMN. Because what are the points favoring pseudobulbar? Her speech appears spastic. She got bilateral facial palatal and tongue weakness, which can occur in LMN and EMN. And tongue is slightly bulky, not the classical UMN tongue which you find. UMN tongue is usually pointed. This is little bulky bilateral. And Georgette is absent. Gag could not be looked for. The patient residue of temperature. So there's a problem here, whether it is really LMN or UMN. Some features are favoring UMN facial cerebral phenomena. Some features are favoring an LMN like absent Georgette. And the tongue appears bulky. It's not the usual UMN tongue. Okay, what do you want now? Now, question now is, now in that case, if it is a lesion is in the midbrain or upper pons, we expect facial pulse to be UMN also, not LMN. Whereas if it was a medullary lesion going up to involve the pons, we expect facial pulse to be LMN. So what test will you to differentiate whether this facial paralysis, bilateral facial paralysis, producing bilateral orbicularis ocular weakness, is actually UMN and not LMN?
Bell's phenomenon, sir.
Yeah, very good. So these are certain small things by which you can try to localize. So looks for the Bell's phenomenon. See, this is what I have done, the Bell's phenomenon.
കണ്ണു തുറന്നേ ആ ഇനി കണ്ണു മുറുക്കി അടയ്ക്കമ്മ അടച്ചേ
Ask you to
അടച്ചേ
close the
അടച്ചേ
eyes.
അടച്ചേ
Eyes are not rolling
മുറുക്ക്
up.
മുറുക്ക് 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 മുറുക്കി അടച്ചേ മുറുക്കി അടച്ചേ
Ask him to close tightly, not moving him. So what does it mean? Bell's phenomenon is absent. That means the facial palsy is UMN. So the lesion will be above the lower pons because it is above the facial nerve nuclear level. So it can be in the upper pons or on the midbrain. Both are possible to explain. The bilateral terminal involvement, more on one side. Now you want, as Umar said, it's an upper pontine lesion extending to the midbrain. So he's got upper pons and midbrain affected. Maximum affected area is the upper pons. Okay. Any questions on that case? They presented with cerebral palsy unmasking with single infarct. Usual situation by hemiplegia. Yes, please come. Any questions?
Why
Now, can you tell me?
how to explain Georgette absent?
Yeah, you are perfectly right. Georgette absent cannot be explained in English. We expect Georgette to be brisk. Okay, I don't know how to explain that. Sometimes, in fact, sometimes may not be elicitable, but we expect it. But I don't know how to explain that. Probably the pontine lesion was extended to the fifth nucleus, probably. That's the only lesion is in the anterior pons also. That is where the problem comes. If the Georgette was brisk, we didn't even consider medullary lesion. Any other questions?
Sir, what was the tongue? Was it like a UML or like a lemon? You said it's bulky and not pointed.
That's another point. What you said is correct. If you have noticed one point in this patient, he has got right-sided UMN tongue, and she's not able to push the tongue towards the right side.
Yeah.
Okay. Normally, in what happens when there is a right-sided lesion, the tip of the tongue deviates to the right side. Okay, but here the tongue is not able to push towards the right side. Isn't it odd? But you see, that is a paradox. That's what happens in human lesion. In human lesion, we expect in human lesion, it is the paralysis of the movement. If left hemisphere is affected, movement towards the right side is affected. The tongue mover towards right side is affected. That is restricted here. Where right hemiplegia and tongue is not, we are unable to push towards right side. But on protruding the tongue, the tip deviates to the right. You got the point. Expecting that overaction of the left genioglossus. The tip is deviated to the right side because the overaction of the left genioglossus. But the other muscles are paralyzed on the right side. That is, it's not to push the tongue towards the right side, towards the cheek. You may see little paradox in that, but that's the things happening in your medication. Why the tongue is not the pointed tongue as you expect in the spastic tongue is that the spasticity of the tongue takes time to develop. Acute human paralysis, this kind of a spastic tongue will not occur. That is why it appears slightly bulky in this patient. So these are the two things which make you confused whether it's actually element or human. In fact, it will fit initially. Spastic speech is favoring human, at the same time, other bulky tongue as well as the absent Georgette could favor element. So that's what you got for other evidence of any human lesion. That is fully for the best. Once you get that, you know the facial pulses, there's lesion is about that. That is about this case. Any questions?
Okay. Is it like how we explain element signs in spinal shock? Can it be explained like that?
No, I can explain like that, but spinal shock means there is no movement. In spinal shock, there's a paralysis first. Then only comes the loss of reflexes and all. If there is not paralysis, it's still able to put out the tongue. But the spasticity is not developed. So that we can't call it as a spinal shock.
One doubt.
Yeah, please.
Sir, the tip of the tongue here, even it is not deviated towards the right on opening out. Like
No. It's actually, if you look very carefully, I'll show the video once again. That part alone.
yes,
The tip is deviated to the right side, but she's not able to push the tongue towards the right. I'll show them once again.
ഇത് പറഞ്ഞേമ്മ നീട്ടിക്കേ നാക്ക് നീ പറഞ്ഞേ നാക്കൊന്ന് നീട്ടിക്കേ
See the tongue
നാക്ക് നീട്ടെ
slightly deviated.
നാക്ക് ഇടത്തോട്ടും വലത്തോട്ടും തള്ളിക്കേ നാക്ക് നീട്ടിക്കേ ബാ തുറന്നേ വാ തുറക്ക്. വാ തുറന്നു. ഇനി ഇടത്തോട്ടും വലത്തോട്ടും തള്ളിക്കേ.
Turning
വലത്തോട്ട്, ഇടത്തോട്ട്.
tip is deviated.
നല്ല വരെ തള്ളി. ഇനി വലത്തോട്ട് തള്ളു. വലത്തോട്ട് തള്ളു. വലത്തോട്ട് തള്ളിക്കേ. ഇനി ഈ വശത്തോട്ട്. ആ തള്ളിക്കേ. വലത്തോട്ട് വരട്ടെ. ഇടത്തോട്ട്.
Tip is deviated.
ഇടത്തോട്ട് നോക്കി തള്ളിക്കേ. ഇനി വലത്തോട്ട്, 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 വലത്തോട്ട്. മൈ കൈ പൊക്കിക്കേമ്മ നോട്ടെ.
Okay.
ഇത് പൊക്കിക്കേ.
Okay, that's a subtle deviation, not a very gross deviation as with classical EMN. Because the other side also paralyzed. Remember that this can occur only if the left side is normal, entirely normal. If the left side is not entirely normal, that's also affected. And that what affected is the genioglossus is the one maximally affected on the left side. Other part is okay. That is why she is able to push the tongue towards the left side. Towards the right side is weak.
Yes, sir. Thank you.
കണ്ണു തുറ.
So this is a subtle thing. So this and show the angiogram of this patient is the basilar artery is totally occluded at the level of the upper pons. Okay, shall I go to the next case now?
Yes, sir, one more doubt. Will you show the angiogram once again?
Angiogram, you are an expert. I don't know. You must teach me.
Just to see only today.
Okay. The opposite vertebral is only single vertebral. Basilar is cut off at the level of the lower part, the mid portion.
Okay.
And the PCOM, PC is separated by the normal and PCOM artery.
There is, sir, it appears like a persistent trigeminal like connection. That's why I thought.
Okay. Yeah, right.
Because it is coming from that cavernous ICA is supplying the basilar actually.
Yeah, that's also possible.
So maybe persistent trigeminal also possible.
But persistent trigeminal sometimes takes a particular sigma sign. No, that is not there.
Because if we proximally trace the basilar, it appears as if it is in one view it is very difficult to comment, but it appears as if it is coming from. I don't know. I might be wrong. You had
No,
already
I
seen
don't know.
the lateral also.
The angiogram, you are an expert. I can't tell.
If you could set the lateral view, what is Umar's opinion? Umar?
Because it is
Because in lateral also it appears like as if it is coming from. Yeah, we need other views also, but it appears as if maybe. That's anyhow not related to the clinical course, sir. I just was like മലയാളത്തിൽ പറയില്ല ക്ഷീരമുള്ള ഒരു അകിടും ചുവട്ടിലെന്നുള്ള പോലെ ആയിപ്പോയത്. Sorry.
Okay, so we'll go to the next.
Looks like.
Okay. Right. He's a story of a 56-year-old man. He was suspected to have pulmonary tuberculosis on an empirical ATT. It's on ATT for pulmonary tuberculosis, for suspected pulmonary T. He presented now with history of radiating paresthesia along the left upper limb 3 weeks back, followed by clumsiness of the left hand. This is the story he gave. No other history. No walking difficulty, no bladder problem. It's something like its history was as you have a radicular disc prolapse or something like that. Okay. Let us see the examination of the patient.
മാക്സിമം പിടിക്കണേ. പിടിച്ചോ.
Deltoid is normal.
കൈ മടക്കിക്കേ.
Biceps is
ഇതും പിടിച്ചേ.
good on the right side. Left side it is weak.
കൈ നൂർത്തി പിടിച്ചേ.
Biceps is good.
നൂർത്തി പിടിച്ചേ. That is good. ഇത് നൂർത്തി പിടിച്ചേ.
That's also good on the right side.
ഇത് ഇങ്ങനെ വെച്ചോണേ. ഇങ്ങനെ വെച്ച് മുകളിലോട്ട്.
Sacral is good on the right side. Normal.
ഇത് മുകളിലോട്ട് പിടിച്ചേ. പിടിച്ചോ.
That is slightly weak.
പൊക്കിക്കോ.
This exercise is normal.
പൊക്കിക്കേ. പൊക്കി പിടിച്ചോണേ.
Slightly weak on the left side.
ഇത് പൊക്കിക്കേ.
Bigger exercise also weak on the left side.
ഇതും പൊക്കി പിടിച്ചേ.
Normal on the right side.
ഒന്നുകൂടെ പൊക്കിക്കേ.
For mild weakness.
ഈ വിരൽ മടക്കി പിടിച്ചേ.
Ankle flexors are all normal.
ഇത് ഏറ്റവും മടക്കി പിടി. മടക്കി പിടിക്കേ. ഒറ്റ മടക്കി പിടിക്കേ. ഇവിടെ ഊരാൻ സമ്മതിക്കില്ലേ? ഊർക്കാൻ സമ്മതിക്കില്ലേ?
It's on the right side figure. Each figure is normal.
ഇത് മടക്കിക്കേ. ഇതൊന്നൊരു മടക്കിക്കേ. മടക്കിക്കേ. ഇത്
Very weak,
മടക്കിക്കേ.
because I'm not very sure.
മടക്കി പിടിച്ചോ.
I can be
ഒരു
protected over.
മടക്കിക്കേ. ഇത് മടക്കി.
The left side,
ഇങ്ങനെ
0 power.
പറ്റണില്ല.
Flexor pollicis longus is
ഇങ്ങനെ
mostly
അങ്ങനെ തള്ളി
affected.
പിടിച്ചോ.
Brevis also is.
പിടിച്ചങ്ങോട്ട്
Flexor
പിടിക്കും.
pollicis
തള്ളി
brevis also
പിടിക്കും.
is.
മാക്സിമം പിടിച്ചോ. ഈ തള്ള് ഇവിടെ പൊങ്ങി നിൽക്കും. ഇത്
Adductor pollicis brevis is weak.
വരണില്ല. ഇങ്ങനെ പിടിച്ചേ. ഇങ്ങനെ പിടിച്ചോണേ.
It is weak on the left side.
ശരി. ഇനി ഇവിടെ പിടിച്ചിട്ട് ഇതിങ്ങനെ ഇങ്ങനെ ഇരിക്കണം. ഇനി പിടിച്ചോ.
Both longus and brevis.
ഓക്കെ. ശരി.
Now,
ഇനി ഈ
taking
വിരലിന്റെ
the
അറ്റം
long
മടക്കി.
plexus,
ഇത്
here
ഇത്
you
മടക്കി.
cannot move the tip of the finger and index finger.
ഇത് മടക്കിക്കേ.
Middle finger you could flex it.
അത് പറയാൻ പറ്റുന്നുണ്ട്. ഓക്കെ. ഇത് മടക്കിക്കേ.
That's also good.
ഇതും പറ്റുന്നുണ്ട്.
That's also weak, slightly weak.
ഓക്കെ.
But all the fingers are weak, but maximum. Brevis,
അറ്റം മടങ്ങരുത്.
sublimates
അറ്റം മടങ്ങാതെ
is
ഇവിടെ പിടിക്കുക.
okay.
അങ്ങനെ പിടിച്ചോ.
Middle
പിടിച്ചോ.
finger.
പിടിച്ചോ. മടക്കിയാൽ അടുത്ത മടക്കിക്കേ. That is good.
But here
ഇത്
the
പിടിക്കാൻ
middle
നോക്കിക്കേ.
finger, index finger, that's also weak.
ശരി. ഇനി വിട്ടെ. ഇത് മടക്ക്. നൂർത്തെ.
Introchet and lumbric, they are weak.
ഇനി ഈ വിരൽ ഇങ്ങോട്ട് തള്ളിക്കേ.
That is
ഇത്
easy.
കാണിച്ചു തരാം. ഇത് കാണിച്ചു തരാം. ഇങ്ങോട്ട് തള്ളി പിടിച്ചോ.
That is on the right side.
തള്ളി പിടി. മാക്സിമം
But
പിടിച്ചേ.
it's also weak. My right might be weak. Not really weak.
ഇതും തള്ളിക്കേ. ഇങ്ങോട്ട് തള്ളി പിടിച്ചേ. തള്ളിപ്പിടി. ഇതിങ്ങോട്ട് തള്ളു.
ADM is also weak.
പിടിച്ചോ.
Then his palmar introchet is also weak. Bilateral weak on the right side.
ഇല്ലേ? ഒന്നുകൂടെ
Common side is
പിടിച്ചോ.
positive on the right side. Not present on the
ഇത് മാത്രം ഇങ്ങനെ പിടിച്ചേക്കെ.
right. Flexus biceps normal. Supinated normal. Biceps normal. Interflexion absent bilateral.
വോളിയമൊക്കെ നോർമൽ അല്ലേ?
Now reflex. Injects are well acceptable. Right angle is absent. Left angle is present. Really acceptable.
ഇത് അറിയുന്നുണ്ടോ കിരികിരാന്ന്?
Sensation vibration
ഇപ്പോഴോ?
equal sensations all normal.
ഇപ്പോഴുണ്ടല്ലോ. ഇപ്പോഴോ?
Telling normal.
ശരി. ഇനി ശ്രദ്ധിച്ചു.
Sensation, pain sensation also equal on both sides.
ഇതൊക്കെ ഒരേപോലെ വ്യത്യാസമില്ലല്ലോ. ഇപ്പോഴേ?
Now, this one you see, right side joint sense is normal, but he makes mistake with the left.
ഇപ്പോഴോ? ഇപ്പോഴേ?
No, he couldn't.
ഇപ്പോഴും അറിയുന്നില്ല.
Some he said yes.
ഇപ്പോഴോ? ഇപ്പോഴേ? ഇപ്പോഴേ?
That he said correctly.
ഇപ്പോഴേ?
Each finger is said correctly. That he made one.
അത്ര ഷുവർ
He was not hesitating to say down or up.
ഇപ്പോഴേ?
Subjectively he said correct. Okay. So these are the findings. So hymen function is normal, cranial is normal. The motor system, right upper limb, that is the limb without is complaint. Weakness of the right elbow flexor was mild. Small muscles of the right hand is weak, including adductor pollicis, because common sign was positive on the right side. Left side, weakness of the left biceps and supination. Triceps power is normal. Weakness of the finger extents is about grade 4. Grade 1 power of thenar muscles, flexor pollicis longus, flexor digitorum profundus of the middle lateral fingers, and flexor sublimis of the left index finger. Grade 3 power of introchet, adductor pollicis, hypothenar muscles, flexor digitorum profundus of the fingers, and flexor sublimis. So this is the weakness we got on the left upper. DTR all normal except absent angle check on the right side. Left angle and knee appears slightly Finger flexion not obtained bilaterally. Sensory, all modalities, prime modalities normal, except impaired joint sense in the left index finger and probably in the middle finger as well. All other sensations, including vibrations and normal. Now, where is your localization?
So, any weakness of lower limb muscles, sir?
No weakness of the lower limb. I did not saw the gait. The gait is also normal.
Any fasciculation, sir?
No fasciculations. His
The root,
complaints
sir.
In which root is affected?
So multiple roots are affected because even starting the lower limbs, the angle jack is lost. One angle jack.
Correct.
So I would put multiple roads as a possibility. It is variously affected, and the sensation also it is not in the fitting with the distribution of a nerve or a plexus.
Okay. So you think multiple routes. Okay, very good. Any other possibility anyone want to voice out?
Multiple nerves also can be involved, sir. It's a mononeuritis multiplex pattern with asymmetric involvement in the upper limbs and ankle absent.
Okay, that sounds another good possibility. Anything else?
Can it be anterior console, sir, like a split hand, like it is more evident in the thinner muscles?
But the problem, but one thing is certain, it's only of 2 weeks duration and you're radiating pain and the joint sense was impaired in the left index. That is very definite. Because all other things he said perfectly correctly, that he made mistake. And there's no fasciculation seen anywhere. Okay, agreed with that. So the point against root is that yes, but biceps and supinator is weak.
There is any possibility of spinal arachnoid?
First we have to come to the site of lesion and then come to the interval. Maybe spinal, if it's a multiple root, definitely you have to think of spinal arachnoid. It's already on ATT for permanent. And he has got some suggestion of a myelopathy because refers the lower limbs are brisk. So that possibility is strong. But before that, we have to find out what is causing his weakness in the upper limb. Is it in the nerve root distribution or a nerve distribution is important. Okay. What against radiculopathy is that the biceps reflex and supine reflex are well elicitable. Even though the biceps muscle is weak. Secondly, point again is that his finger flexion is weak on the left side. Abductor pollicis longus is weak on the left side, but the triceps reflex is there. So they are separated by the C7. That reflex appears again well elicited. So in fact, radiculopathy usually reflex goes first before the weakness, but that's not always be true. It depends upon whether the anterior root is more affected or not. Third point is that the point that come later on. Third point, why it says. So what do you want now?
Can it be plexitis?
Plexitis is possible because it can have a very patchy involvement. But it's got bilateral effect. Right side is also affected. Bilateral plexus involvement is very uncommon. And that would affect the lower station involvement. The same points against radiculopathy is also applicable for plexitis. Because the same muscles which are affected have got a normal reflexes.
The spinal arachnoid test.
Okay, so you want MRI, no? You wanted MRI, cervical myelopathy with radiculopathy. Okay, this is MRI. Normal.
Conduction studies.
Sir.
Normal, the contrast also. Okay, so what do you want now?
So contrast is not done already?
No, contrast is normal. I did not show that thing.
Nerve conduction studies.
Okay,
for that MRI of the plexus.
MRI of the plexus.
Yeah, yes, sir. MRI of the plexus.
But that in both sides, no? Okay.
Yes, sir.
No, I did not do that. The reason I'll come later on. No, you wanted NCS, no? Somebody wanted it. But why do you want NCS in this patient?
I would like to get a CCS study.
Because radiculopathy, you don't find any abnormal real. We can't diagnose radiculopathy with NCS.
Because
roots were the nerves involvement.
Pardon?
So to look for snaps.
Snaps, sir.
You look for the snap abnormality. Correct. Okay, that's not the real reason why the way they should be done in this patient. Now look at the look at the next video. There are certain things which make us strike that this is multiple nerve. His weakness is where is a maximum weakness is in the flexor digitorum longus of the index finger, and that is the area where his joints is also lost. So that pattern goes for what? This is the, I'll show the video now. It's a pointing index sign. When you get a pointing index and pointing thumb sign, has to be a nerve involvement because it takes the typical pattern of that median nerve involvement. So you got other nerves involved, but median is also getting involved. So it has things of a mononeuritis multiplex. Of course, your point of doing NCV, find out snap is important, very good. But this is another point by which you want to know its lesion is likely to be in the nerve itself. So now the pointing index sign, this cannot occur in a human lesion. Because this is the myelopathy kind which you can human lesion, where the maximum involvement may be in the middle two fingers that get flexed and then sometimes flexed at the metacarpophalangeal joints and separated out. The little finger goes out. That so-called finger escape sign. But element will not, a human will not produce this kind of hand appearance. That is, the pointing index will not occur. Okay. If you find that, that means it's an element in the median. So NCV was done, which shows right median CMAP is decreased, left CMAP is decreased, ulnar is decreased, and no sensory potential. That means it's not a radiculopathy at all. Both median and ulnar have no sensory potential. FAV is absent from the absent on the median and ulnar. So what is likely diagnosis? It's a mononeuritis
multiplex.
So his ANGA was strongly positive, and I do not know the subsequent course in this patient because I saw the patient once in only one time. So his ANGA was subsequently found that he was treated as vasculitis and improved. The red herring was that he was having pulmonary tuberculosis. That when you see multiple weakness in the element, we try to think in terms of multiple radiculopathy. There's a commonly we have a tendency to diagnose. But the medical examiner tells you that the pattern is not fitting with the root, pattern is fitting with the nerve. You have to pursue that way. Okay, any questions in that case?
Sir, any finding the lower limb is right angle was absent.
Right angle, right angle NCS, I don't know because I only shown you this thing. I don't know whether it's affected on my tablet. Because right, definitely left angle is quite brisk, right is absent, mean that.
Yes, sir.
His earlier pulmonary disease also may not be.
Yeah, that may not be. What you said, this is correct. That's what they said. Presumed pulmonary TB is already on ATT and came to us with a complaint. So we have to look again whether it's really pulmonary tuberculosis or some pulmonary fibrosis secondary to the connective disease. The point is very good. Yeah.
Sir, one more doubt.
Yeah, please.
The elbow flexion was deep, but the biceps is very elicitable.
Which is elicitable?
Biceps reflex was elicitable, no, sir?
Yeah, very, very elicitable. Yeah. That's elicitable. Not that means even the muscle is weak, that is elicitable. So that can mean that the involvement of the muscle motor involvement is not complete.
Yes, sir.
Yeah, in radiculopathy, why the reflex is lost early is because the afferent involvement.
Yes.
If the sensory part is normal, the motor part affection means the reflex loss is proportional to the muscle loss. So you may not get a reflex loss all the time.
So the radiculopathy that itself shows the radiculopathy.
If it's a radiculopathy, the reflex tends to be lost earlier than the other findings.
Yes, sir.
Yeah.
So in this patient, how are you sure that the plexus is also not involved by EMG wise, sir?
By the EMG wise, you can't differentiate between the two, but the pattern, when EMG wise, this can go with plexus involvement. Perfectly right. But what plexus involvement will you consider like that bilaterally? What etiological possibility? It's more like a multiple nerve involvement. Okay. Right.
Okay, thank you, sir.
I'll go to the next case.
Sir, any nerve biopsy done in this case? No biopsy.
And since Sangha was positive, other immune-mediated markers were also positive, and was treated accordingly. I don't think the MNC was done in this patient, biopsy was done in this patient. Once the other parameters, when the pattern is multiplex and you find Anga positive and other things, you can lung involvement probably due to that, as someone was. So I think more like a connected disease. Now biopsy have been more confirmed. Agreed. Okay. Shall I go to the next case? No, this is actually
steroids or any other statin infection.
I did not hear you. Can you repeat it?
Was it given only steroids or other cytotoxic drugs?
Frankly, I do not know, because this case was not my case. I was working in Pushpagiri.
Yeah.
I this case once a time. Subsequently, it was treated subsequently. I do not know what happened to the patient. The only case is brought for the localization, how to approach and localize.
Okay.
So this is a story of a 14-year-old boy. Why I am this case? I have shown a similar case before. I am going to show two similar cases. This is a very common problem which come across in practice, but often you find difficult to diagnose. That's why I thought I will bring it again. This boy has come with episodic blurring of vision for the last 2 months. Look at the eye movement. You must look at the finger to the right, left, up. Up and to the left side, up and to the right, up and to the lower and low and to the right, low and to the left side. So if you find that finding, what will be your conclusion? What do you think? Or I'll show one more thing. I'll show 2 frames in this patient. See, I'll show 2 frames from the same patient. The patient is asked to look at one point of time when you look carefully. Otherwise, ocular movements are all normal. But at this point, right left eye is not adducting as much as the right abduction of the right eye. Obvious, no? It's not. It's a disconjugation there.
Yes, sir.
Yeah. Now this frame, on looking to the left side, there is a disconjugation. Here it appears that right eye is not adducting. The first one, left eye is not adducting. Here the right eye is not adducting. So what will you think now?
Any possible myasthenia, sir?
Yeah, it could be myasthenia, correct?
Can it be that the patient has a squint and is fixating with either eye and the other eye is...
Perfectly right, perfectly right. Let's see. But we have to keep the post-myasthenia, as Umar was telling. But you see, if you look at the movement was equal in both sides. That also you should keep in mind. Even though there is a interfering, look at both eyes, the range is equal. The amount of movement with the right eye is the same as the amount of the movement with the left eye. It moves in equal velocity in all the directions. Even though the alignment is different, the range of movement is equal. If it had been due to a weakness, the range of movement should be restricted in that particular direction. It was not there. Okay. So that makes you suspect that. So from that time onwards, you start thinking it is something where brain condition like a concomitant skin. So what do you find there? On left eye seems not to attack as much as subject on the right eye when the patient looks to the right side. The right eye seems not to attack as much as subject on the left eye when the patient looks to the left. There's two frames which are shown. The range of movement of the yaw muscle seems okay. Now we have to find out whether the disconjugation is due to a paralytic or concomitant skin. I'll come to that. Now here, the disconjugation may appear only at certain times. That's a confusion. Here also, sometimes the skin may not be that obvious. Patient may look apparently normal without any skin. Sometimes you have any skin, then you get confused as to what it is. I will show you the first thing to differentiate is to find out whether if you find something like a squint episodically or otherwise, is it a typical tropia or a manifest? Tropia means manifest squint, or a phoria. Phoria means latent squint. What is latent squint? This patient is inherently, we all have some degree of squint, some kind of a latent squint or phoria, but we are able to overcome that latent squint by our fusional virgin system. That system makes your, even though your one eye is little abducted, that system make that abducting a little adduct and make it parallel so that you can have a binocular vision and fusion is made possible. So the image is made to fall on corresponding part of the retina of both sides, and you won't develop any diplopia. So you can fuse the images and I can have a stereoscopic vision. That is why this fusional virgin system we have with you, even the state split. But if the squint is more, if the deviation is more, our fusional system can put this into parallel and you will develop diplopia. So then, how to just find out what is tropy and phoria. Tropy is an established or seen squint. Phoria, an unseen squint. Unseen means you are not seeing a squint at that point of time. Let us see how to differentiate.
Covering test.
Somebody can please can mute your mic. Sorry, speak. Please come. Please mute the mic, please. Please speaking. Yeah. So how to diagnose is by cover uncover to find out. You know what do you do? Cover uncover test is you cover one eye and see, can you move the person's mind? In cover uncover test, you cover one eye at a time, binocular vision in between. Let us see this patient. Just one. Can you see? Sorry, my connection went in between. I'll restart the screen once again. Can you see my slide now?
Yes, sir.
Yes, sir.
Okay. Now, you can hear me also, no? Can you hear me?
Yes, sir.
Okay.
Yes, sir.
Okay. Sorry, it in between, went in between. So what I was trying to say is that tropia you diagnose by cover-uncover test to find out tropia. You cover one eye at a time with normal binocular vision. Let us see this patient. This patient's eyes appears almost parallel without any problem in looking in one particular direction. So what I'm going to do now is a cover-uncover test. Covered one eye. Nothing is happening to the uncovered eye. Always look at the uncovered eye. Nothing is happening. Now I'm covering the other eye. Again, nothing is happening to the other eye, uncovered eye. That means this patient does not have it properly. This manifest being already there. Then you do cover uncover. Movement of the eye is not there in this. So that means this patient is not proper. Let us see what I'm going to do. So there is no deviation in the uncovered eye. That means there is no tropia. Now, what will you do to find out a latent squint or phoria which is masked by your binocular vision? Somehow you have to block your binocular vision at a time. So you do alternate cover test. That means there should not be a binocular vision in between at all to break the fusional divergence. If you give binocular vision, both eyes open, the divergent system will act. To prevent the divergent system act, you should never have a binocular vision, do cover one eye and immediately switch to the other eye. So that always you are maintaining vision with only one eye. That is the purpose of the alternate cover test. Let us this particular patient. I'm going to the cover. You see the movement of the right eye. Shift the cover, movement of the left eye. That means yes, got a phoria, latent squint, which you are blocking because you are covering one eye, so that is only has to fix with one eye. Now what is happening? Under cover, the eye has gone to this lazy position. So when you shift the cover to the viewing eye, the lazy position eye will come back again. I will show that I have made some diagram for you to make it understand a little more easier. That I will show later on. So this patient's got a heterophoria or a latent squint. Now let us see the eyes in the eccentric position. This eccentric position of the patient. Okay. There is a manifest in this position. Now, the phoria, even though initially we found that the primary part there is no deviation. Now there is a deviation. That is in that position, you have to do the cover uncover test. I mean, in that position, he has got a tropia, this manifest. Now he can combine a blurring of vision and diplopia because eyes has become disconjugated. If you find such a phenomenon, if you find a tropia, it's a manifest skin. Now you differentiate whether it's a paralytic or concomitant. We don't know now whether it's due to the middle paralysis or due to a concomitant squint. It's not only malalignment, no real weakness. So what will you do now? You can do the duction testing. What is duction testing means? You cover one eye and check the ocular movement of the other eye. See, for example, closing the right eye in all directions. Full range of movement in all directions. That means it is not a paralysis. That's one way of testing it. The second point favoring is that look for the primary and secondary deviation. What is primary and secondary deviation? Primary deviation is the deviation of the squinting eye or the bad eye when the patient fixated with the normal eye. The bad eye may be paralytic or concomitant. Okay. Whereas second deviation is the deviation occurring in the normal eye when the bad eye is fixing, when the paralytic or weak eye is fixing. Let us see this particular patient now. I am blocking one eye. He's doing with the left eye now. Doing with the right eye now.
Okay.
The deviation is equal. If it had been one eye had been paralytic, that movement, the paralytic had been paralytic. When the patient fixated with the normal eye, that paralytic deviation be much less compared to the deviation of the normal eye. Or I make it when the paralytic eye is made to fix, the normal eye has to move much more because according to the Hering's law of equal inversion. So I'll make it clear to you by showing this particular diagram. Come back to this particular patient.
Okay.
So testing malalignment, this already told you. How to do the cover uncover test? Patient is asked to fixate a distant object, for example, pencil head in the hand. A cover is placed in front of one eye and removed, and the cover is placed in the other eye and removed. It's already told before. Let us see, for example, here. This is a cover uncover test. This patient has got left eye is adducted or deviated medially. We call it esotropia. Okay, but this skin may be subtle. Sometimes when just looking at you may not be able to find out. So if the right eye was fixing earlier and the left eye was a squinting eye as shown in the diagram, when you put a cover in the left eye, what will happen to the right eye? Nothing will happen. Look, he's already viewing it. So you won't find it. That means the right eye is normal. There is no trophy in the right eye. Now you shift the cover to the left side, to the opposite side, onto the right eye. That is the eye which was fixing earlier. Now the left eye, which is already squinted, had to go back and fixate on that object. So what did you find? When you put a cover on the right side for the right eye, the left eye deviates. That means he has got a tropia of the left eye. So that is the cover and cover test. Now for the alternate cover test, here the patient is asked to fixate on an object. Then one eye is covered for at least 4 seconds and then cover is shifted to the opposite side. The examiner should always look on the uncovered eye. So this is latent squint. So what happens is that in the case of Fourier, when you cover the eye with latent squint, the covered eye loses fixation and assumes the position of rest, is the original lazy position or latent deviate, because it is no longer has to fixate an object. It goes into its original lazy position or phoric position. Because the patient views, because when the patient with both eyes, the fusional emergent system corrects the squint. So when you want cover one eye, there is no need for the fusional emergence to operate. The eye in which the squint was present goes back to its lazy position. When you shift the covered eye is uncovered, it refixates on moving back. Let us see this picture. Now here, the both eyes looks parallel, no? There is no squint, apparently no squint. But truly, this left eye is actually has got esophoria. That means latent squint in the left eye. But you are not seeing it because the patient is viewing with both eyes. The fusional emergent system makes it aligned and parallel. Now what happens? Suppose you put a cover on the left eye, which is esophoric originally. That need not looking at the object, no effort on the fusional emergent system. So it goes its original lazy position, that is adducted position on the left eye, which we call as the esophoria because it's adducted. Now what happened is that when you shift the cover to the normal side, normal eye, the left eye has come back and refixates. So what does it mean? Originally there was no squint. When you put a cover onto the viewing eye or fixating eye, the eye which was deviated now come back. Because by putting in one cover on the other side, we have made that eye go into lazy position. When you shift the cover, you can find out the already deviated position of the lazy eye. So you can diagnose the heterophoria. That is the principle of alternate cover test. Okay. Then and one more thing I have to tell is that if tropia is present, the examiner should determine whether it's competent or non-competent. Competence refers to whether or not ocular misalignment is the same in all directions of case. That is competent when the deviations are equal in all directions. Incompetent means when the deviations are more in one case than the other. How to find out that incompetent is due to the paralysis. Comitant is congenital causes. The degree of malalignment is constant in all directions, but each eye has got full range of motion. So how to differentiate? Look for duction movement, as I already told you. Duction movements are normal. Duction movement, close one eye, look for the eye movement. Is normal in competent strabismus, whereas ductions are restricted in some direction in incompetent strabismus. Second thing, you look for primary and secondary deviation. What is primary deviation? Primary deviation is the deviation of the lazy eye or paretic eye when the good eye or the normal eye fixate on the object. Secondary deviation is the deviation of the good eye or non-paretic eye when the lazy eye is forced to fixate on the object. The secondary deviation is always greater than the primary deviation in non-competent or paralytic strabismus because of the Hering's law of equalization. So, for example, let's find out this one. Here, the left eye is the good eye, right eye is the deviating eye. Okay, so this is the primary deviation. He is fixing with the good eye, that's the left eye is good, right eye is deviating, that deviation is called the primary deviation. Now you block the normal eye, that means the right eye has no fixate. So suppose there's got some paralysis in the right lateral rectus, that is why the eye has gone medial. You have to put extra innervation to the right lateral rectus to make it straightforward. Okay. The same extra innervation goes to the left medial rectus also, the corresponding yaw muscle. So you need to produce only 10 impulses for adduction. Now it have to 20 impulses for the right eye. That 20 impulses goes to the left eye as well. So the eye will overshoot or produce much more deviation than the primary deviation. Now what will you find? This deviation is the deviation of the normal eye under cover is much more than the deviation of the paralytic eye. That's called the secondary deviation. Okay, so you understood now the principle of the tropia, phobia, and all, tropia, phoria, as well as the primary and secondary deviation. Now I'll show you another case, somewhat similar case. Again, this case is from Dr. Roy from Town Medical College. In fact, this boy gives.
Sir,
but
one doubt.
Yeah, please.
Sir, one doubt, sir. Regarding this this patient who has a latent squint. So in such patients, do they come with intermittent diplopia? In that case, what should we think of, sir?
Yeah, in fact, the commonest cause of intermittent diplopia is not myasthenia, is manifest latent squint. That is how these tests are done to differentiate. In myasthenia, it is due to the paralysis, at least transient paralysis. You can differentiate by you can differentiate by the duction movement, and you can differentiate by the looking for the primary and secondary deviation.
Okay, sir.
Okay. Now, similar case I will tell you. This boy gave a history of something very much mimicking a myasthenia. Episodic diplopia after playing football for some time, especially when looking at distant objects for the last 2 weeks. He was perfectly all right prior to that. And it disappears by closing eye for some time. The diplopia will disappear, he begins to come back. Okay, so it develops diplopia on exertion. So let us see the ocular movement of this patient. In the sitting position, there is minus deviation inside, but the movements are okay. To the right. Now I ask him whether it's diplopia. He said no diplopia. Even now there is no diplopia. He said there is mild diplopia. Tip is diplopia. Now he says no. Now he says yes. Now it's diplopia. Okay. Now look at the position now. See? Now, is it ocular? See the position of the eye? Left eye is slightly deviate inside after going on looking in that direction. Is it ocular myasthenia? The confusion comes, no? Whether it's ocular myasthenia or not. So let us see whether it's a paralytic or concomitant. What test will you do? See the next video.
അത് നോക്ക്, തുമ്പത്ത് നോക്ക്, വേറെ എവിടെയും നോക്കരുത് ഇയാൾ കേട്ടോ. നോക്ക് നോക്ക്, തുമ്പത്ത് തന്നെ നോക്കണേ. നോക്ക്, തുമ്പത്ത് നോക്ക്. ആ, ഞാൻ പറഞ്ഞല്ലോ തുമ്പത്ത് നോക്കണം, വേറെ എങ്ങും നോക്കരുത്.
Now I am going to do the
തുമ്പത്തെ നോക്കാവുള്ളേ.
our test to find out whether primary and secondary deviation is equal or not. That's
തുമ്പത്തെ നോക്കാവുള്ളേ.
degree movement is equal. That means there is no primary and secondary deviation are equal. So just appear to be a paralytic. Sorry. Then I will show the latter part of the video.
Okay.
The same link to find out the primary and secondary.
നോക്കിക്കോ, ഇയാളുടെ ജോലി ഒന്നേ ഉള്ളൂ, തുമ്പത്ത് നോക്കുക, വേറെ എങ്ങും നോക്കരുത് കേട്ടോ.
Okay. Let us see. So he has got tropia on the left side. Now you see paralytic concomitant, what it is said, sequence unlikely to be paralytic. Now how to confirm again, look at the next video, check the ocular movement.
Okay. ഒന്നും നോക്കരുതേ, ഇനി വെള്ളി നോക്ക്.
Ocular movements are normal. The concomitants can also become manifest when the eye gets fatigued.
The range will be fully normal ആയിരിക്കും.
Range is normal now.
മുകളിൽ.
Okay.
അതെ.
But subtle movement will
ഉണ്ട്. രണ്ടും കൂടെ നോക്കുമ്പോൾ it appears weak because he is fixing the right eye. ഇവിടെ നോക്ക്, ഇവിടെ നോക്ക്. ഇപ്പൊ appears laterally speaking, അല്ലേ? വെള്ളി നോക്കടാ, നീ വേറെ നോക്കില്ല. Appears like that.
Left eye is, but on covering the right eye comes. So this is how to differentiate myasthenia. If it was myasthenia, the patient was going on looking at the left side. Okay, which left side? The eye fatigues and come back to the primary position, a little bit adducted position like this. Okay. In the case, if it is due to a concomitant squint, you close the right eye, that becomes correct. That means he is fixing now with the right eye, not because of his weakness of the left abduct. If it is myasthenia, even if you close the right eye, the eye will remain at that position because it's fatigued. The abduction will continue to remain like that because it's already fatigued. Understood? So you can differentiate. Now I am asking to close the right eye.
ഇപ്പൊ നീ വെള്ളി നോക്കടാ, നീ വേറെ നോക്കില്ല. Appears like that.
Now it's getting right. That means now it's mixing with the left eye. That shows it is not myasthenia. It's a concomitant squint. That's superiors. Okay. Any questions in that?
Sir, how do we look for spasm of accommodation?
Spasm of accommodation. You mean to say what took place in the convergent spasm?
Yeah, sometimes I had one patient where everything started suddenly. Patient was coming back after writing an exam. Then he started complaining of diplopia actually. And like this patient, movements were completely normal. Two of the previous neurologists diagnosed it as a myasthenia, but there was no improvement with the empiric treatment and
that is exactly the same case as my case. This is a concomitant squint. The squint became manifest because continue the reading. What happened? Continued watching the TV. Your infusional version system gets fatigued out. So the latent squint, which is so far corrected by infusional system, breaks down, and the diplopia will become manifest. Blurring will become manifest. So what you have to do? You close the eye for some time, give rest to the eye, then look again, no diplopia. So you'll confuse with myasthenia. So that is the reason why you have to do this test to find out whether the fatigability or the episodicity is due to actually a concomitant squint where it's a breaking of the diffusional system, or due to the paralysis of the extraocular, weakness of fatigability of the paralysis of the extraocular muscle. In the case of in your case also, if the patient has got a squint or diplopia at that time, when you close one eye, there won't be any restriction movement in any direction. Whereas in myasthenia, even if there is close one eye, that weakness will persist. Okay. Second point, you continue to the person suspect myasthenia looking in one direction, suspect diplopia. Ask to go on looking in that direction. the diplopia will slowly manifest in both concomitant spin as well as in myasthenia because they are fatiguing the muscle. To differentiate is that in that case, it's already fatigued, the eye back, it will come back to this lazy position so that only one eye is fixing. Now you don't know whether it's because the concomitant spin, the good eye is fixing, lazy has gone out at lazy position, or the muscle has come back because of the fatigability of that muscle. In that position, just close one eye, the eye will switch back to the target or that the apparent weakness is corrected in concomitant spin, but not in myasthenia. Myasthenia is the muscle is fatigued. Whether you close the other eye or not, that muscle is not going to recover. You understand? That's the way to do. That's what I did in this particular child. Did I answer that question, Hak? And what about your question was accommodation spasm? That is seen in convergent spasm, membrane lesion, where the eye convergence, because the convergent spasm, the eye goes into adducted position. So you get an apparent restriction of the abduction called a pseudo-abduction palsy. To diagnose from lateral rectus weakness is look for the meiosis. There is a convergent spasm, there will be meiosis as well. Okay.
Okay.
Shall we stop here or give for one more case?
One more case.
One more case.
Okay. It's a 24-year-old male. He complaint started 12 years back as loosening of the chapels from the left foot. 1 year later, he noticed difficulty in elevating the left foot, along with numbness of the dorsum of the left foot. Okay. Along with this, he also noticed thinning of the left leg. The story is 12 years back, loosening of chapels. 1 year later, noticed difficulty in elevating the left foot and numbness. Again, I noticed thinning of the left foot. He was admitted in a major hospital and surgery was done in the back. However, he denied any improvement following the surgery. For the last 4 years, he developed weakness in elevating the right foot, along with numbness and waning pain in the right dorsum. This was followed 2 years later by sagging of the hip while walking. Okay, that means maybe called hip abducted weakness. So first started left side, now 4 years right side. History of perseverance in micturition for the last 2 months. Okay. So the history wise, what will you think the likely situation will be? Some patient, the
Kodaikan.
Let us see the patient. So on examination, he is continuing on the left side. Deflection is normal.
Straight eye.
Knee extension is normal. Dorsiflexion is slightly weak on the right side, but very good, but very grossly weak on the left side. It is also grossly weak. That is weak on the right side. And normal. Side is weak. But support as long as it's weak. It is good for
നീ കാല് ഇങ്ങനെ പിടിക്കണം, അകത്തോട്ട് പിടിക്കണേ,
English.
വെളിലോട്ടാക്കാൻ സമ്മതിക്കരുതേ,
good for the right side.
ഇങ്ങോട്ട് പിടിച്ച് അകത്തോട്ടാക്കാൻ സമ്മതിക്കരുത്.
Inversion is normal.
നീ ഇത് വെളിലോട്ട് എടുക്കാൻ നോക്കിക്കേ, പറ്റണില്ല, അകത്തോട്ട് എടുക്കാൻ നോക്കിക്കേ,
Inversion is not weak.
സമ്മതിക്കരുത് തന്നെ കേട്ടോ.
Hip abduction is weak.
അത് പിടി, ഞാൻ മാറ്റത്തെ പിടിച്ചോണ്ടിരിക്കണേ,
It is weak on the right
ഇത്
side.
പിടിച്ചോണ്ടിരിക്കണേ.
Left side is okay. Main weakness problem.
കാല് ചേർത്ത് വെച്ച്, ചേർത്ത് വെക്കണം,
Abduction is
ചേർത്ത് വെക്കണം. ശരി, ഇനി കമ്മിയുടെ നേരെ പൊക്കണം, ഈ കാലാണ് പൊക്കിക്ക്, ഇത് നേരെ പൊക്കണേല, അങ്ങനെയല്ല, അങ്ങനെയല്ല, അങ്ങനെ പൊക്കി പിടിച്ചോ, പിടിച്ചോ, പൊക്ക് 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 പൊക്ക്.
almost normal. Weak, slightly weak. Of course.
ഇത്
Left
പൊക്കിക്ക്
side is severely weak.
പറ്റണില്ല, നോക്കട്ടെ.
Hamstrings also
ഞാൻ
weak.
പിടിച്ചുതരാം, പിടിച്ചുതരാം, വിട്ടോ. അതിന്റെ മുകളിലോട്ട് 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 ഇനി പിടിക്കാൻ നോക്കി, പിടിച്ച് നിർത്തിക്കേ, പറ്റണില്ല
This is
അല്ലേ?
really weak.
ഓക്കെ, ഇത് മടക്കിക്കേ, മടക്കിക്കേ, മടക്കി മടക്കിപ്പിടി, ഇത് മടക്കിക്കേ,
Hamstrings weak by that, but severely more.
Marking.
They're on the right side.
മടക്കിക്കേ,
They're on the left side.
ഇതിങ്ങനെ മടക്കിക്കേ.
No, reflexes is normal in the upper limb. Abdominal reflux was absent, fatigable. Tells it now, but after 3 times it becomes absent. Especially the lower part. Rejects are brisk. Angle is absent.
ലൂസായിട്ട് ഒന്നും ചെയ്യരുത്. കണ്ണടക്കി എണ്ണി ഒന്നിന്ന് ഉറക്കിയുണ്ട് മോനെ. ഉറക്കിയിട്ടില്ല, 1-2 നിലയിലും മതി. ഉറക്കേ
That is invade over the left lobe. Save time and series per day. They decrease pain.
അവിടെ കൂടി ഇതും വ്യത്യാസമുണ്ടോ?
It is difference between the
ഇവിടെ മരിച്ചിരിക്കുക. ഇതും കൂടുമ്പോൾ പറയണം. ഇതും വ്യത്യാസമുണ്ടോ? അവിടെ മരിച്ചിരിക്കുക. കൂടുമ്പോൾ പറയണം.
Okay.
കൂടെ പറയാമോ?
The examination. That's also invade. Mainly on the left. Negative. And it's a gate to the patient.
തിരിച്ചു വന്നെ തിരിച്ചു ഇനി ഒന്നുകൂടെ നടന്നു. തിരിച്ചു വന്ന്
Okay, so
ശരി മതി. തിരിച്ചൊരു കാര്യം. ഓക്കെ, ഇനി മറ്റേ കാര്യം
on the left leg we keep sags going
നോക്ക് മതി.
Okay. Now on examination, wasting of both the legs, more left more than the right. Power, right lower limb, all normal except for the weakness of the left THL. Grade 4 power, so not the left THL, right THL. Grade 4 power with those flexes, knee extensions and knee flexes. Left lower limb, hip flexion, adduction normal, abduction grade 4, extension grade 2 plus, knee extensions normal, flexion grade 3 plus, angle dorsiflexion, pantarflexion, inversion grade 1. So reflexes abdominal reflex absent except in the right upper quadrant. DTR, knee checks brisk, angle absent, plantar sensory or decrease over the dorsum of the both feet. Negative. So what is the diagnosis? Straightforward, please. Anyone? Not much of a problem.
Conus cauda, sir.
Yeah, why conus? There's no bladder involvement. Oh, yes, got symptoms. Yeah,
Bladder.
correct. Conus cauda. Why not cauda equine itself?
Because there is the abdominal reflex.
Okay, it's absent. If in conus cauda, you expect the reject to be brisk in that case. If the reflex, the lesion has to extend upward to produce absent abdominal. Do you expect reject to be brisk?
No.
No. So he has definitely cauda-equine lesion. Face when radical jacks are absent. The weakness is exactly in the distribution of their roots. Bladder may be involved, right?
Multiple levels.
Yeah, what condition will you keep in mind? He was operated early. Acronoiditis. Okay, very good. Post-operative is a possibility. So I'll show the MRI in this picture. I will not tell, you tell the diagnosis. Okay, I'll show the one more, all the pictures I'll show. This is the sagittal cut. This is the T1 weighted sequence. This is axial cut.
Is tethered cord, sir?
Exactly. So you can see the canal, it is operated earlier. These all roots are going posteriorly and attached to the dura there. See, these are all the roots attached to the dura. You can again find out there's the enhancement in the roots attached to the posterior part. Now go back to the axial cut. You see, the spinal cord is extending much lower down. These roots are all clumped together and going attached to the posterior part of the dura. This is the scar of the previous surgery, and this is also root attached. Now, see again, you can find out the root going back and attached posteriorly. It's all clumped roots together. Again, attached posteriorly here. Then it comes lower down. It goes. All the roots are going towards the posterior aspect and attached to the dura. So this is tethered cord syndrome. Now, when you suspect tethered cord syndrome, there is a corda-equine lesion and find some suggestion of pyramidal involvement just above. You think of tethered cord. Why do they develop pyramidal signs?
Stretching of the cord.
Exactly. This because the cord the roots are anchoring the spinal cord to the dura down. So as the patient grows up, there will be a pull onto the spinal cord, and then there are the pyramidal signs. Okay, this only not a problem in analyzing, but I thought I'll bring because of the combination of LM and UMN findings. Okay. Any questions in that case?
Sir, any markers like in neurocutaneous markers in this case?
No, in fact, he must have had a lipoma there. It was operated. Now, no longer, only we can see the operated scar. The history was there, no? 12 years back, he was submitted for surgery.
Sir, regarding the spasm, how do we treat that spasm of accommodation? Is it like covering one eye for a few days will do some help?
No, that
boy who was having diplopia after.
We don't call it as a spasm because the eye position is forward position. That's called isotrope.
Okay.
What you have to do is that not cover one eye, go to Virgin's exercise. I teach them Virgin, ask him to accommodate to suppose it is weakness of the make the fusional system more perfect. Ask him to converge and diverge to the exercise like that. That will do good for this patient. And in fact, no other treatment. If you can give
this boy is still having problem.
Yeah, I can give spectacle with the prism lens. What will prism lens do with that? There's a peculiar. Have you seen that class with the prism?
Sir, where is it available, sir? We searched here. It was not prism lens. Sir.
If you see the lens, you can get something like a vertical groove will be there in that glass. That with what the prism does is that depending upon it is the adducted position, abducting position, you can have a prism which is made inward or outward. That point of the prism may be inside or outside, so that the rays reflected, so that's made on fall onto the this thing, the battery. That is the purpose of the prism.
Sir, is it available, sir?
Yeah, it's contact optometrist. That is in good ophthalmological centers. For example, if you go to some Netralaya, the Aravind Hospital, and medical college, they do that. Ophthalmology department of ophthalmology. So such high centers, they will do that. Because in ophthalmologists, they will do it.
Sir, Huck, you can ask your wife. Actually, he is much afraid. Maybe that's the reason.
There were two patients similar, sir. Both of them were diagnosed as myasthenia from elsewhere. In fact, they were not myasthenia. I thought it is spasm of accommodation. However, still having a problem.
See, when I complete my TM and start my practice, the first mistake I did was I diagnosed it with myasthenia. And I put the patient steroid, and patient was booming. I was swelling like anything with no improvement. And subsequently, I came to know that they suddenly manifested skin. That is why I'm taking these sort of cases, because it's very, very common. Very common. And many of
നമ്മൾ പഠിക്കുമ്പോ ഒന്നും കാണുന്നില്ല, പുറത്തിറക്കിയിട്ടാ കാണുന്നത് സാർ, അതാ പ്രശ്നം.
because they are not getting admitted. Yeah, that's a problem. Okay then.
Okay, sir.
So,
Okay, sir.
okay.
Thank you, sir.
Sir, good day, sir. Thank you, sir. Thank you very much.
Thank you, sir.
Thank you, sir.
We'll meet next time.
Thank you, sir.